just in case, to explain the concept. So the cell has fluid inside of it. There's fluid between the cells and there's fluid within the blood vessel, and this fluid is plasma. The fluid that is inside of the cell is the same concentration as the 0.9% sodium. So it has the same concentration of sodium chloride. Anywhere sodium goes in the body, water is going to follow it, right? So anywhere sodium goes in the body, water will follow it. So if your patient has 0.9% of sodium, so let me put 0.9% sodium here. So let's say this is your NS, normal saline, 0.9%. Let me enlarge that. So you give a patient a fluid with 0.9% sodium chloride. If the fluid that you give the patient has a higher level of sodium than what is inside the cell, right? I wonder if I can put it here. So let's see if I can type within it. 0.9% NS. Right? So if you give an IV fluid that has a higher concentration of sodium chloride than what is inside the cell, then water will move outside of the cell. Everybody understand that concept? Raise your hand if you got that clearly. Come on. Okay. Right? So if you give a concentration that is higher, you give a fluid that is higher in sodium, higher than 0.9% sodium chloride, that's a higher concentration than what is in the cell, water will move from the cell into the bloodstream, right? So the cell will shrink. Now, when a fluid pulls water from the cell, it is referred to as a hypertonic solution. So that's what we call a hypertonic solution. Now let's get rid of this arrow. So let's say I remove that. You give the patient a fluid that has a lower concentration of sodium chloride than what is in the cell. So if we give a patient a fluid with a concentration of sodium that is less than 0.9%, which direction is the fluid going to flow? Is it going to flow outside of the cell or flow into the cell? That's a question. So the cell will now start to pull fluid in, and it will eventually swell up, and it can swell to the point that it bursts. Now, when we give a fluid that is lower in its concentration than what is inside the cell, it is referred to as a hypotonic solution. Now, what happens if we give a fluid? So we give a fluid, pencil, with the same concentration. So you give a fluid that has the same concentration of 0.9% sodium chloride than what is inside the cell. So it's the same concentration than what is in the cell. That's a 0.9% normal saline. Where is the fluid going to move? So it has the same concentration, right? So the fluid is now able to move in and out of the cell without changing the shape of the cell. So the shape of the cell is not affected and the fluid is moving in and out of the cell. This is what is referred to as an isotonic solution. So isotonic solutions do not change the shape of cells and it tend to remain in the vascular space, which is where we want it. So isotonic solutions are the solutions that we utilize in the pre-hospital setting. And these are the three solutions. Normal saline, which is sodium chloride. So it's normal saline, 0.9% sodium chloride, which is salt water. 5% dextrose in water, which is it's isotonic in the bag, but once it enters the body, it becomes a hypotonic solution. So 5% dextrose in water is hypotonic in the bag, isotonic in the bag, but when it enters the body, the sugar is rapidly absorbed and then the water follows the sugar. So it becomes a hypotonic solution. Lactated ringers is similar in its concentration to sodium chloride. The difference is lactated ringers have more electrolytes in it and it also has lactate. Lactate is something that can be converted into bicarbonate by the liver, which is useful if a patient has acidosis. Right? So that's lactated ringers. Similar in its concentration, meaning that the electrolytes that it have the same concentration in the body. So it acts as an isotonic solution, but it also has lactate, which can be converted by the liver to bicarbonate, and bicarbonate is a buffer for acids in the body, right? So it helps to reduce acidosis in the body. There is no clinical evidence to show that lactated ringers is better than normal saline, but it is wise, well, I wouldn't say wise, it is a practice to use lactated ringers in patients that we suspect is having some type of acidosis. For instance, if I have a patient with diabetic ketoacidosis, then lactated ringers might be beneficial to that patient over normal saline, but there's no evidence to show that one is better than the other. So these are your solutions, right? So that's that. Now, the final thing I will say to you is that when you're going to, you have a question, Mr. Jones?
Yes, sir. Can you go over the 5% dextrose in water? You said it is isotonic in the bag, but when it gets out of the bag, what happens to it?
So the 5% dextrose in water is an isotonic solution, just like normal saline and lactated ringers. But when you put that solution into a patient's vein, right? So when you start to run the 5% dextrose in water into the patient's veins, the sugar that is in that solution will be rapidly absorbed by the cells. And when the cells pick up that sugar, water will follow it as well. So the cell will also absorb water as it absorbs the sugar. When that occurs, it becomes a hypotonic solution because it's causing fluid to be pulled into the cell. You got that? I don't remember if it was Mr. Jones or Washington. Did you get that? Okay. All right. Now, the final thing I will mention to you as it relates to your fluids. There are some things I need to keep in mind, right? We have gone over fluid resuscitation based on 3-to-1 principle, fluid resuscitation based on body weight per kilogram, fluid resuscitation based on bolus administration. Some important things that you need to remember. If you have a patient with internal bleeding, so if a patient is bleeding internally, you will give fluid in a manner, whether it's based on their body weight or bolus. The fluid that you're going to administer should not normalize their blood pressure. So you don't want a normal blood pressure for a patient that is bleeding internally. You want the blood pressure between the systolic between 90 and 100 millimeters of mercury. So if somebody is bleeding internally and you're giving fluid, the goal is to get to a blood pressure systolic of 90 to 100 millimeters of mercury. We don't want to millimeters of mercury. We don't want to normalize their blood pressure. If the blood pressure goes any higher than that, their clotting factors will start to be diluted, right? In other words, their blood is going to thin out, and that's not good if they need to go into surgery. So that's for internal bleeding. If your patient has a head injury, so if the patient has a head injury and you need to give fluids for fluid resuscitation, you want a systolic between 110 and 120. So if you suspect that they might be at risk for significant complication, raised ICP, you want a systolic blood pressure of 110 to 120 when you're giving fluids for these patients. So you don't want a low blood pressure in a patient with a head injury, right? That's a rule of thumb. So for head injury, 110 to 120 systolic. For internal bleeding, 90 to 100. Now finally, if you have a patient in distributive shock that you need to give fluids, this patient is going to take a lot of fluids. So you may have to administer between 1 to 2 liters of fluids to patients in distributive shock as boluses, but you will do it in increments of 500 mils. So what does that mean? I have a patient with distributive shock. I need to do fluid resuscitation. I'm going to give 2 liters of fluid, but I'm starting off with 500 first. So I give 500 mils as a bolus, reassess the patient, level of consciousness, peripheral pulse, where's the blood pressure. Then I give another 500 mil. Then I give another 500 mil. So each 500 mil, I'm re-evaluating the patient, right? So they can take a lot of fluids. So up to 2 liters may be required for a patient in distributive shock. And these are just a few key things that you need to keep in mind, right? Because at the end of the day, IV fluid is not blood, so it doesn't replace blood, right? The IV fluid is just expanding the vascular space or blood volume until the patient can actually get the blood if it is necessary. Now, definitely for some patients, the IV fluid will be beneficial, especially for your patients that are dehydrated. But when it comes to blood loss, the patient is going to need blood. So the IV fluid is just buying time. So you cannot just run an IV fluid and it's not being controlled or monitored. You're going to dilute the patient's clotting factors if they have internal bleeding. And that's not good for the patient if they need to go into surgery. For your head injury patient, it's too dangerous for their blood pressure to go below 90 for the systolic. So we try and keep their blood pressure systolic in 110 to 120 because we don't want a patient with head injury to develop cerebral perfusion, drop in cerebral perfusion pressure. And for your distributive shock patient, it's going to take a lot of fluid. These patients take a lot of fluid. And that's that.